Hi everyone, and welcome to another video for the JJ&J Cardiac Surgery Critical Care Academic Program. For March, we've decided to have a cardiac output as our theme, and we're very excited to delve into it. Why do you need to know about cardiac output? We've already measuring blood pressure on the regular, and now we're bringing in cardiac output. Why are we doing this to you guys? Cardiac output is basically our life force. Blood pressure is the amount of pressure exerted on our artery walls. Cardiac output takes a lot more into consideration. It's metabolic rate, it's flow, it's the heart rate, many factors involved to ensure adequate delivery of oxygen-rich blood to brain and other vital organs. Okay, so bear with me here. Cardiac output has quite a few equations in. So this is where the maths part comes in, but it's completely doable maths. So let's have a look there on that right-hand side. We've got cardiac output equals heart rate times stroke volume. Cardiac output is defined as the amount of blood pumped by the heart in 1 minute. Stroke volume is the amount of blood ejected by the ventricles in 1 beat of the heart, which is milliliters per beat. Heart rate is the amount of beats of the heart in 1 minute, beats per minute. So therefore, if we have a look at our equation, cardiac output equals heart rate times stroke volume, and heart rate being measured as beats in a minute and stroke volume as mils in a beat, we can cancel those two beat values out, and we can say cardiac output is measured in mils per minute, or a volume per minute. Our normal heart rate is around 70 beats per minute, and thank goodness for the sum, stroke volume is around 70 mils per beat. So we can say the average person's cardiac output is 70 times 70, 4,900 mils per minute, or easier, 4.9 liters per minute. Or even easier, if we round it off, around 5 to 6 liters per minute at rest. I said on average. What does that mean? Have a look at these 4 patients. Do you think the 5 to 6 liters would be adequate for all of them? Maybe too much, maybe too little. So how are we going to sort this out? We are all about science, and we're not going to do plus minus. We need patient-specific cardiac output. Voila! Cardiac index is the solution to this problem. And cardiac index caters for all different size humans, thank goodness, as well as their cardiac output normals. So how do we get that? We add body surface area into our equation to provide for all the extra cells added by height and weight or lack thereof. So cardiac index is simply cardiac output divided by body surface area. How do we calculate body surface area? So here's our equation on the screen now. It's in meters squared, and you'll see we need a very accurate height in centimeters and a weight in kilograms to work this out. Thank goodness we don't actually have to do this in practice. The way in which we measure cardiac index is with a cardiac output monitor, and as long as you put these 2 values in, the technology works it out for you. But if you're wondering how it does it, this is the equation that is used. But what I want to highlight here is the accuracy of this information that we input into our monitor, which is the height and weight. Please, nurses, keep a measuring tape with you. There's no excuse not to have an accurate height for your patient. Sometimes the weight might be a little bit more difficult if your patient's symptomatic and you can't get onto a scale. But please try when the physio does come, when you do have that one mobilization, to get a proper weight. Your patient will tell you a weight from months, maybe even years ago. Okay, but do not eyeball it. Try and add a bit of science into the mix so that we can get an accurate body surface area, so we can get an accurate cardiac index. Okay, so coming back to our main equation, which is cardiac output equals heart rate times stroke volume. What makes up stroke volume? There are three factors that directly impact stroke volume and therefore directly impact our cardiac output. And we're going to delve into these three now. We have preload, we have contractility, and we have afterload. So what is preload? Preload is how much volume is there for the ventricle to squeeze out or contract or systole. Remember, all of those words mean the same thing. How much volume has the ventricle got to work with and to squeeze out? That is your preload. Contractility is all about the strength or the force of that squeeze that the ventricle has. How powerful is the ventricular squeeze or contraction? That's all about contractility. Afterload is how much resistance must the ventricle overcome to be able to squeeze. And another way of saying that is how much resistance must the ventricle overcome to open up your aortic valve on the left and your pulmonary valve on the right. So we can say there are four factors that will influence cardiac output, and they are heart rate, preload, contractility, and afterload. Let's start with heart rate. Heart rate is set by our SA node, our sinoatrial node in our right atrium. Normal heart rate is around 60 to 80 beats per minute at rest, but we say sinus rhythm can go from 60 to 100 beats per minute. And all the factors influencing heart rate fall under the word chronotropy. Those of us here in South Africa that work in private healthcare, and I'm not sure about government too, but we have a system that works on our time and how many shifts we do called Chronos. Everybody knows Chronos, and we're now talking about chronotropy. It's all about time and rate. Okay, so when you hear chronotropy, we must think heart rate. A positive chronotrope will increase your heart rate. A negative chronotrope will reduce your heart rate. So let's have a look now at the factors that will have a positive chronotropic effect. In other words, increase our heart rate. There's many factors that can do this, but some of the ones worth mentioning, I think, in this cardiac output setting is our sympathetic nervous system will secrete NORAD and epinephrine, which we call adrenaline. Okay? And NORAD, noradrenaline. Those two are very powerful chronotropic agents that increase your heart rate. Anything that works on your beta receptors, and remember they're divided into beta 1 and beta 2, but anything influencing beta will increase your heart rate. Our hormones increase our heart rate. T3 and T4 increase our metabolic rates, our thyroid hormones. This is why thyroid hormones are often part of a cardiac workup, to check what's happening with T3 and T4, and is that why we've got this strange heart rate? Ions, which are fancy words for electrolytes, an increase in calcium will have a chronotropic effect. Remember, calcium works on our action potentials, and the more that we have, the faster the heart rate will be. We've got chemoreceptors sitting in our aortic arch just above that will sense a decreased oxygen, hypoxia, or increased CO2, a decrease in pH, so acidosis, and in that setting, it will stimulate our acceleratory center in our medulla, and will have an increased heart rate and an increased respiration rate to try and compensate for those three things that it sensed. A pyrexia will increase your heart rate. Exercise Anxiety. How many of the patients in the ICU are anxious? All of them, if they're awake, and even those that are not. Pain. Hypovolemia. Anemia. There's many conditions that will give you a elevated heart rate. Drugs that we give, examples, atropine, Dobutrex. Okay. So you can see there's many things that are happening in our patients that will increase our heart rate. So if you see your patient's heart rate going up, you must be able to do a bit of detective work and figure out why is this happening. And we need to think about some of these reasons. Okay, on the flip side, we have negative chronotropics, things that decrease our heart rate. That'll be our parasympathetic nervous system, acetylcholine. If we have a decrease in calcium levels, a decrease in potassium levels, those are both ions. The action potential is decreased of our heart in the setting of hypokalemia, as potassium cannot leave the cell as easily because the gradient is too high vascularly. So we'll have a decrease in our heart rate. Let's talk about bradycardia. So there's many things, like we said, that will have a negative chronotropic effect. Parasympathetic nervous system, some of the drugs we give. But endurance health is a very interesting one. Have you ever had a patient that's quite a good athlete? You put them onto the monitor and their heart rate is like 48. And you're like, oh my goodness, the dude's bradycardic. Whereas it's quite normal for him. And why is that? When they undergo endurance training, they're exercising their heart muscle. And in time, the heart muscle becomes so strong that the contractility part is so good and the preload is more than yours or mine, perhaps, increasing the stroke volume. And to compensate for that increase in stroke volume, we're not just going to have a hypertensive patient. So our bodies readjust and we'll develop a lower heart rate to compensate for that increase or overachieving stroke volume to give us a normal cardiac output at rest. And that is why they have these lower heart rates. Okay, let's talk more about those three factors that make up our stroke volume. First one being preload. What is it exactly? So preload is the stretch. It's the end diastolic volume. What is that again? It's the amount of blood that is in the ventricles available for the systole, for the contraction or the squeeze. So at the end of diastole, the amount of blood that's sitting in your ventricles, remember 80% of it fills passively, the other 20% comes from your atrial kick. So when your atria contract and squeeze that last little bit of blood out of the atria into the ventricle, ready for the next phase, when the ventricles squeeze, that is your end diastolic volume. And we get that during relaxation of the ventricles. Okay, so factors influencing our preload. There are quite a few. One of them being venous return. So our veins bring back deoxygenated blood through a whole big network, eventually emptying into our right atrium via the superior vena cava and inferior vena cava and coronary sinus. But along the way, our muscles actually have a tone and assist to squeeze a little bit and increase our venous return and increase the flow of the veins. They call this muscular milking. We also have a respiratory pump. So as we breathe, the pressure inside our intrathoracic increases and our abdominal decreases. And these increases and decreases as we breathe between our abdominal cavity and the thoracic cavity also increases the amount of blood that comes back to the heart, increasing our venous return. We have venomotor tone and we have venoconstriction. Remember also CPAP, continuous positive airway pressure, is a continuous pressure in our thorax now from our respiratory system that will decrease your venous return, as the pressure is simply continuously too high to get nice filling into our hearts. So bear that in mind when you put someone on CPAP. Another factor that influences preload is filling time. So we said our cardiac output equation, as we increase the heart rate, we should get more cardiac output. And that is true to a certain extent. As we start running, our heart rate will respond. As we have a fever, our heart rate will respond, and try and keep our cardiac output at a certain level. But there's a caveat to that, and that is when we go too fast. When we start hitting dysrhythmias like SVTs and sinus tachycardias that are very high, 150 and above, we can start imagining that because the heart is beating so quickly, it's not having adequate time to fill up. The preload doesn't have enough time to reach the ventricle. So now it's just squeezing tiny little amounts, and because of that fast heart rate, we're getting a decrease in our stroke volume. And because of that, we won't have the effect of the heart rate on the cardiac output. So there is a limit to it. Another factor, and something that we should know about, is Frank Starling's law. And Frank Starling's law was all about cross bridges in the myocytes of the heart. So what is this now? So as you fill the heart up with preload, with volume, we create more of a stretch in that ventricle. And the more stretch that you have, the bigger the contraction will be. Think of it as an elastic band. As you stretch it more and more, it will be flung further across the room because the contraction is much bigger. We say the cross bridges in the heart are increased by a bigger stretch. But once again, similarly to the filling time, there's a caveat. If you've got a sick ventricle, a fibrous cartilaginous tissue there, or a patient that's had many MIs or remodeling from heart failure, which is all the same, it eventually becomes non-compliant to almost being overfilled. And once you do that, you start going into pulmonary edema. The ventricle simply doesn't cope with the amount of preload you're giving, and you might have the opposite effect then. Okay, so let's look again at a bit of maths for stroke volume. Here's another equation for you. Stroke volume is equal to EDV minus ESV. And what are those again? End diastolic volume minus end systolic volume. So let's just think about that. End diastolic volume is the amount of blood that's available to the ventricle now to contract with. So at the end of diastole, it's the amount of blood filling the ventricles. ESV, end systolic volume, will be the amount of blood in the ventricles after systole. So when our ventricles eject, they don't eject all of the blood. We're not trying to create a vacuum in our hearts. Okay, there's always a little bit of blood there. And that blood that's left over at the end of systole is the ESV, end systolic volume. So our end diastolic volume is around 120 mils. Our end systolic volume is around 50 mils. If we take the diastolic volume away from the systolic, we've got 70 mils left of stroke volume. That is the amount that's actually squeezed out by the ventricle during systole. Another interesting little equation, because we get this often in our cardiac world, is we talk about what is the patient's EF, what is our patient's ejection fraction. So that's directly these measurements I was telling you about now. It's stroke volume over end diastolic volume. So what percentage of that volume, the end diastolic volume that's available to the ventricle, did it actually squeeze out? Remember, stroke volume is the amount that it actually squeezes out. So if our end diastolic volume was 120 mils and our heart managed to have a stroke volume of 70 mils, so 70 mils of the 120 was squeezed out, that will give us a 58% ejection fraction. And that is completely normal. A normal ejection fraction is 50 to 70%. None of us have 100% ejection fraction. We're not looking for metric goals here for percents for ejection fraction. We're looking for 50 to 70%. We say 41 to 49 is reduced, and less than 40 is severely reduced. And then we're looking for reasons. Could be heart failure, could be MI. What is the reason that the heart is not ejecting enough stroke volume out? All this information we can get from cardiac output monitoring, our volumes, and our ejection fraction we can also get on an echo. Okay, let's move on to the second factor, which is contractility. We said contractility is the strength. It's the ability of the cardiomyocytes to contract. It's the systole of the ventricles, the force of ventricular contraction. Okay, and the term that we are going to use to talk about contractility is inotropy, factors influencing the force of our heart's contractions. If we say something is a positive inotrope, it strengthens the heart's force. If it's a negative inotrope, it weakens the heart's force. Let's look at our positives. Okay, so once again, our sympathetic nervous system will secrete NORAD, epi or adrenaline, and it will act on beta-1 receptors. This is a sympathetic nervous response. Our hormones, once again, the thyroid hormones T3, T4, but as well as glucagon increases beta-1 binding receptors, which will also have a positive inotropic effect. Calcium, yet again, very important in our action potential. If it is increased, we will have more inotropy. Chemoreceptors will also form a part of this if they detect hypoxia, hypercapnia, and acidosis. Drugs that we give that are positive inotropes: atropine, Wobutrex, dopamine, digitalis, adrenaline, noradrenaline. We've got many inotropes, and they all work in different places in our cardiac output. They are not prescribed randomly or based on who is what prescriber's favorite. They all have specific receptors at different levels, and we need to understand our patient's cardiac output to prescribe, but also to maintain our inotropes. We will do a section on inotropes in coming months, but this is the lead up to that. This is the theory so that you can understand how we are using inotropes. Okay, so on the negative side, something that weakens the heart's force, a negative inotrope, will be again parasympathetic nervous system, acetylcholine, the lowered calcium, the lowered potassium, and acidosis. Drugs that we give that are negative inotropes are calcium channel blockers, our hypertension medication, and beta blockers. Right, the third factor is afterload. And this one is special because it is inversely proportional to cardiac output. So in the case of the other two, the more preload, the more cardiac output. The more contractility, the more cardiac output. This one is the opposite. The more afterload, the less cardiac output. And why is that? Afterload is the amount of resistance the heart must overcome to open the aortic or pulmonary valve to be able to eject. It's got another name, SVR, systemic vascular resistance. So it's all the arteries and arterioles, the diameter of them. If they're very narrow, there's going to be a higher resistance, and it's going to be tougher for our heart to be able to eject. If they're very dilated, it's much easier, but our blood pressure will be lower. Just remember, afterload is inversely proportional to cardiac output. So what are some of the factors that influence afterload? increasing factors, things that increase our afterload, there are some structural ones like valve stenosis. Think about our aortic valve, the valve between our left ventricle and aorta. If it's very stenosed, which means the opening is narrowed for whatever reason, might be calcium buildup, it will be more difficult for the ventricle to push blood through it. Like drinking a double thick milkshake with a tiny little straw is much more difficult. Nowadays, if you order something like that, you get a big thick straw because of that exact thing. The afterload is too high. Another structural reason might be a non-compliant aorta, or plaque buildup in the aorta will also narrow it. If it's not able to stretch very well, it will also have a high afterload, our aorta itself. Our vascular resistance, so that's all the arteries and arterioles. Our smooth muscle contraction will increase our afterload. It will increase our SVR, our systemic vascular resistance. Hypertension is exactly that. The viscosity of blood will increase your afterload. So if your blood is very thick, like the double thick milkshake, it will be more difficult to eject. Smoking, we know, causes vasoconstriction, which will also increase our SVR. Stress has the sympathetic nervous response, remember? Adrenaline, NORAD works on our alpha receptors, causing a narrowing or a constriction as well. The cold, hypothermic patients will definitely have an increased afterload, causes everything to narrow up. And drugs that we give that work on increasing afterload are vasopressors, phenylephrine, vasopressin. Some of our inotropes at high doses also act on our alpha-adrenergic receptors, and that will increase our blood pressure, increasing our SVR, increasing our afterload. If it's indicated, it will also increase our cardiac output, but if we take it too far, we make the work of the ventricle way too difficult. So there's a lot to consider when taking afterload into account. What are some of the factors that reduce afterload? Afterload reduction. So if we have a valve regurgitation, an incompetent valve, the blood can travel in two different directions, which is not ideal, but it will reduce afterload. Pyrexia reduces afterload because it vasodilates. Vasodilation also occurs with sepsis as well as vasoplegia. A therapeutic afterload reduction technique we use is intra-aortic balloon pump therapy, counterpulsation, which will reduce afterload in a situation where you want less work on your left ventricle. And some of the drugs we use, vasodilators, Isocet, nitrocine, TNT spray. Think of nitrous oxide that we give through a ventilator. All of those are vasodilation to reduce afterload. I want to make a point about blood pressure. Blood pressure also has an equation, and it comes from an old physics law called Ohm's law. Ohm's law is pressure is equal to flow times resistance. So we are now measuring all these things. Blood pressure, therefore, is equal to cardiac output times SVR. Remember, SVR is systemic vascular resistance or afterload. So in a situation where we are increasing our inotropes constantly, or our pressors, whilst only measuring our blood pressure, it's not adequate to actually say that our patient has got adequate cardiac output or a safe SVR. And a safe SVR is, to me, a safe afterload is when we don't have too much of a narrowing on the supply of oxygen-rich blood to our other organs. So going up and up and up with inotropes to get some sort of resistance in our aorta, to get some sort of blood pressure, is not okay if it means we are compromising on the supply of blood to our other organs. The first one that takes a knock is our kidneys. If we vasoconstrict those arteries and arterioles that supply kidneys too much just to get a normal blood pressure without sorting out the actual problem, without knowing what factor it is that's actually causing us to have a low cardiac output, whether it's preload, contractility, or afterload, we are actually just compromising the patient. We're not doing them any favors. Right, so with all this in mind, with all these factors in mind, how do we measure cardiac output? So before we get to cardiac output monitors, there are things we do in our daily practice all the time. We talk to the patient, we're assessing neuroobs, we're seeing if they're orientated to time and place. How does this equate to measuring cardiac output? If they're neurologically intact or the same as they were, you would expect there to be an adequate cardiac output because of the cerebral perfusion pressure that then therefore exists. We know then their brains are receiving adequate amount of oxygen-rich blood. The same principle applies to urine output, which we are measuring hourly. If we're satisfied with a urine output of 0.5 ml per kilo per hour, we know our kidneys are receiving enough perfusion, enough oxygen-rich blood. Even simpler, we do blood pressure every hour with our other normal vitals. We should be checking capillary refill on our peripheries. If it's abnormally slow, it could be a sign of decreased cardiac output. We should be measuring our peripheral pulses and comparing the two. We also generally look at the skin's pallor and temperature. If we've got a cold, clammy patient, it's probably from a low cardiac output state. We measure our temperature. We do blood gas measurements quite often, maybe a bit too often. We're looking at lactate. Remember, that's something to give you confidence that your patient is receiving enough cardiac output if your lactate levels are adequate. The first thing that will happen is your body will go into anaerobic respiration if it's not receiving enough oxygen. And if it's a perfusion issue, we then go into anaerobic respiration, and the end product will be an increase in lactate. That's a huge warning. Either there's a respiratory problem with hypoxia, or we're not delivering enough oxygen-rich blood to our cells. So if your lactate level is low, under 2, which is normal, and your blood pressure is a little bit low, you'll know that it's adequate for the patient. I always see lactate as a confidence booster. A normal lactate, that is. After all these things that we do quite regularly, we might then add a non-invasive cardiac output monitor. And in what instance would we then add this? To me, when we start guessing, when we're not sure whether to give fluid for a bit more preload, or whether to give inotropes, and which inotropes. Do we want to target beta 1, beta 2, or the alpha? If we're not sure, we take all that guesswork out, put a cardiac output monitor on, and it will give us determinants for preload, contractility, afterload, and we can make better decisions for our patients. This is indicated in cardiogenic shock, post-open heart surgery, the cardiogenic shock from a big MI, septic shock. There are many different states where we can use this technology to your patient's benefit and to give you confidence as not only a clinician with our doctors, but also maintaining all these inotropes through a 24-hour shift. It gives us a lot of information that we can use, and it will empower us to give us the best decision-making process for our patient. We also then have invasive cardiac output monitoring, which is not very common in our area, but that is pulmonary artery catheters or Swan GANs. Don't forget CVP monitoring as well. Most of our patients in ICU have a CVP. This should be transduced on the brown lumen, on the most distal lumen, so we can get the most accurate value. And this is also a good determinant of preload. Remember, if you're using cardiac output monitoring, you must have a properly transduced CVP. It's going to use that reading to work this out for you. On this note about cardiac output, we are, as JJ&J, co-hosting a cardiac output workshop with Gettinger on the 8th of March. We are fully booked for this one, so thank you to the enormous response we've had for this. We will see you guys at Redlands, and you will all become masters of the cardiac output monitor. But please don't worry if you didn't manage to get a live in-house seat. We will record this event and you will be able to watch it. Also, the theme for April in the JJ&J academic training is hemodynamic and cardiac output monitoring. So this month we're talking about the theory, and next month we'll teach you more about the practice. But in between, we've got this wonderful workshop that we are so excited to attend. I just want to recap again. Go through those equations and make sure you understand cardiac output equals heart rate times stroke volume. Stroke volume is dependent on 3 factors: preload, contractility, and afterload. And make sure you know the difference between those 3. Get that solidified in your academic practice so that we can understand how to apply inotropes, which is a huge part of our day in the ICU. I'm there for you guys. I will see you guys in the units. We can talk more about this. We'll also have a Q&A at the end for the people that are not in our region. But otherwise, I'll see you in the units. Please WhatsApp if you need to. And remember, on our academic program hosted on the JJ&J website, we now have registration available. Please hit the registration button, fill in a few of the requirements, and we will add you to a mailing list where you'll get all the updates and all the links to everything that we're doing. Look out for our journal club posts as well there, and our grand round write-ups. There's so much to learn, and we're going to do it together. Bye.